Hi everyone, my name is Stefan. I'm a pulmonologist subspecializing in interstitial lung disease or ILD. In this Bits of ILD series, this is number 2, I'll be talking about this condition, idiopathic pulmonary fibrosis or IPF. It's a fairly long presentation, I will let you know by now, but I tried to actually put together everything in one presentation because sometimes it's useful to have all the information there. And even this is not all of it. It's a very complex disease. It's a condition that has a high mortality rate. It's quite debilitating. It's something that you would need to recognize. So if you are a medical student, consider learning about IPF because you may encounter this in clinical practice, and it can be very, very confusing, even for clinicians with experience, to understand how it's classified, what it means, and how to make a diagnosis. And believe me, in clinical practice, I see a lot of referrals from other doctors who may not understand exactly how to diagnose the condition. So I think it's important to talk about it. So if you have a cup of tea to listen to this presentation, it might be useful for you. I have a little glass of water, so I'll try to go over everything slowly and hope to make it as clear as possible. I don't have a lot of very fancy visual aids here, but I'll be trying to talk you through IPF and what it means. So feel free to just listen to this if this is easier for you. Before I begin though, I need to put a little bit of a disclaimer. This is not a presentation that consists of medical advice. So this is not medical advice if you are a patient suffering from IPF, because your condition may be completely different than what I'm presenting here. Everyone is different. So do consult your doctor if you have any issues. Similarly, if you're a healthcare provider, do consider that, the information presented here may not apply to your patient. So use your own clinical judgment, and you are of course responsible for the decisions that you make. But I need to make these statements before. I think it's helpful because you find a lot of information online. It's important to put it in the right context. But that being said, I would like to actually go over some objectives I have for this presentation, and hopefully you'll find them helpful. And actually it's very, very thorough. So I want to help you understand what the typical IPF presentation is, what's the typical patient, what are the requirements for making a diagnosis of IPF, because there are quite a few things you need to go through. Understand why a careful clinical history and a relevant panel of investigations is required. This is because you need a lot of things to make a diagnosis of IPF, which is a diagnosis of exclusion. So it's very, very important to emphasize aspects of the differential diagnosis, to outline treatment possibilities and expectations. So I'll talk about treatment a little bit towards the end. To emphasize the role of the wider ILD team. You're not a sole clinician when you're diagnosing IPF. You need other people around you. You need expertise from many clinicians. You need to integrate the information that you're getting from all the tests, from your clinical investigation, from radiology, pathology, etc. To integrate all this information into the wider scope of ILDs. You're not only looking for IPF when you're making a diagnosis of IPF. You're looking for other things, ruling them out and making a diagnosis of IPF. So that being said, what is IPF? This is something that we need to start talking about slowly. So it's probably the most well-known interstitial lung disease. Well, there are many interstitial lung diseases, but this one, if you mention lung fibrosis, people might think about IPF, although there are many other conditions. It's the most common of the idiopathic interstitial pneumonias, or IIPs. These IIPs are part of a classification of interstitial lung diseases. So they're a group of conditions, very funny acronyms. I won't go over them here, but IPF is one of the acronyms, and it's the most common of that one group. But basically IPF, idiopathic pulmonary fibrosis, just means lung scarring of an indeterminate cause. It's an umbrella term. It's a diagnosis of exclusion. It's a distinct disease, but it's also an umbrella term because you have many phenotypes of disease within IPF. And I think that's very hard to understand sometimes, but it is, however, a progressive, irreversible form of lung fibrosis. The life expectancy, the median life expectancy, is around 3 to 5 years, which is quite grim if you think about it. But obviously, when you have a patient who might ask you about this, because they will go online, they will look this up and they will ask you, 3 to 5 years is a median. There are many patients who survive way longer than that. There are patients who actually progress faster than that. So it's important to set the scene correctly and to give them some sort of reassurance, because many patients will be scared when they receive this diagnosis, especially when they read about it online. So it's important to understand what you can offer them and to give them as much reassurance as you can and support. I think that's the only thing you can do as a doctor, really, besides offering treatment. So to make a diagnosis of IPF, it's important to rule out known causes of lung fibrosis. These can be caused by rheumatological disease, connective tissue disease, for example, scleroderma, Sjogren's, etc. These can cause lung fibrosis. So you need to rule these out because they would be treated differently compared to IPF. Exposures in the environment. If there's something in the environment that's causing lung fibrosis, that's not IPF. You remove the exposure and the patient might get better. Or is it an offending drug? Is it something that the patient's started taking recently that caused the lung fibrosis? These things need to be ruled out. So you need a lot of expertise when you're diagnosing IPF to actually rule out a lot of things. It's a very interesting field of medicine. And IPF this is very important because it's thought to be a purely fibrotic lung condition. It used to be thought that it's inflammatory. It was treated with corticosteroids, but some studies have shown that actually high doses of steroids in IPF are detrimental. They make the patients worse. They give worse outcomes. So you don't treat IPF with steroids, with corticosteroids, with prednisolone, things like that, unless there's an exacerbation, but that's completely different. But generally, you're trying to target the fibrotic pathways. So basically, if we were to summarize a little bit what is IPF, it's a condition, this is a bit of a mouthful, it's a condition of impaired lung repair mechanisms. So basically what happens is the lung may be aging prematurely, and this is probably rooted in genetics quite a lot, and I think that's fascinating if you think about it. It's just that many IPF patients have had quite a lot of lung exposures. You may not have an environmental exposure per se that causes the disease, but they may have worked in environments with lots of dust. They may have been builders, etc. They may have smoked a lot. There may have been injuries to the lungs, and somehow, because maybe an environmental genetic combination, their fibrotic response was exaggerated. It doesn't stop once it starts, and you have a progressive fibrosis. It starts in the periphery of the lung and it sort of encompasses the whole lung. And this is very complicated. We don't really understand why this happens, but that's the theory related to fibroblasts, related to cells that produce collagen that seem to be dysregulated. Something's going on there. So that's what causes really IPF. The prevalence of IPF increases with age. So it's a condition of older age. So the older we get, the prevalence increases. The incidence generally is about 3 to 9 per 100,000 per year. So this incidence is also rising, and that may be in part due to better awareness of the condition and better diagnosis, more rapid diagnosis, but also there seems to be an increase that's not explained only by that. So these are things that are important to mention before. I have this article here. This is basically where you can find more information about the incidence and prevalence. Pitfalls, very important to mention this before we go into the rest of the presentation, which, you know, it might be a bit long, granted, but I think it's important to mention all these things. Not all lung fibrosis is IPF. Very important. Many clinicians do not understand this. So it's important to make the distinction between IPF and other causes of lung fibrosis. The prognosis and the treatment are different. Why did I put this here? It's because we need to recognize other causes of lung fibrosis. We need to have quite a broad expertise when we're diagnosing IPF. I mean, don't be discouraged by this. It's something that will come with time, but basically you're trying to rule out other things to make this diagnosis. So when someone has lung fibrosis, you don't automatically call it IPF. Idiopathic, you need to make sure it's definitely idiopathic. The MDT, the multidisciplinary team discussion, is very helpful in this sense because you're working as part of an ILD team. Generally, when you're trying to diagnose conditions like IPF, everyone brings a little bit of expertise. You might have a radiologist on board in that meeting. You might have a rheumatologist, you might have specialist nurses, you might have a pathologist, a lung specialist. All these people bring something to the table and they try to make decisions in the benefit of the patients to get the best possible diagnosis, the most accurate possible diagnosis. The typical patient with IPF, I think that's very important to mention, and I did say that I would go over this in the beginning, is someone who's generally slightly older, maybe over 65, 70. They have a progressive shortness of breath and dry cough that seems to occur and progresses over months to years. They also have on physical examination fine crepitations on lung auscultation, so fine crackles, Velcro crackles as they are called, in the periphery and basal parts of the lung. And these seem to be sort of going progressively higher and higher if you repeat the auscultation months after, etc. So this is the typical patient. They may also have finger clubbing on physical examination. So these things are generally quite typical. When you see this presentation, you should think really about IPF. The diagnosis is complex. This is where I think we need to slowly go over a lot of things. So you need a comprehensive evaluation. You're trying to rule out a lot of things. And in this presentation, I'll try to show you what we're trying to rule out as a principle to make sure we get the correct diagnosis. So we need a careful clinical history, obviously the timeline of progression. How long did it take to progress to this stage? Was it quick? Have they been forever like this? Environmental exposure is very important to note, because something in the environment can be triggering the disease. It could be some sort of moldy hay, birds, things like that the patient's keeping, which may be triggering the condition. Smoking is important again. Lung injury, think about that. Medication history. Was there a drug that the patient started recently that may have caused the fibrosis? Family history, very important. If they've had a brother with IPF, that's a big red flag. You need to consider that as well. Symptoms suggestive of systemic disorders like connective tissue diseases, scleroderma, for example, rheumatoid arthritis, things like that. The physical examination helps you check for these things. So obviously very important to do not only a chest examination, to look at your patient top to bottom if you can, and try to determine whether there are signs of connective tissue disease. I think that's key when you're making a diagnosis of IPF. Comorbidities are important because these need to be treated well to provide the best outcomes possible for your patient. A high-resolution CT scan of the chest is the cornerstone of the diagnosis. You can't really make a diagnosis of IPF based on a low-resolution scan or something, or some contrast scan. You need a high-resolution CT scan to actually define the pattern of fibrosis, and I think that's very important. It's not always accessible for all clinicians. I mean, it's accessible. It can be done with most CT scanners, but you need to have a radiologist who can do that, and to request it specifically as an HR CT scan. I'm sorry to insist on this, but it's very important. Pulmonary function tests, again, very important. The spirometry and the transfer factor, they are very helpful in monitoring the disease progression. They also sometimes, when the DLC on the spirometry, they're not really giving you similar or corresponding results. It can suggest that there may be other things at play. So very important to have very good pulmonary function tests done. Autoimmune screening, so autoantibodies, you would do an autoantibody check to rule out connective tissue disease. You may sometimes do a bronchoscopy with a bronchoalveolar lavage or BAL, because the differential cell count can sometimes make the distinction between fibrotic versus inflammatory causes, and that really is very important when you're treating a patient. Even if you're not getting to the best correct diagnosis, if you can make the distinction between it's an inflammatory ILD versus a fibrotic ILD, you're already very close to providing better care. And then in very rare cases, you may need a surgical lung biopsy. It's very rarely required though. And obviously all this data is then ideally discussed in this ILD multidisciplinary team discussion, because everyone brings some expertise to the table. They discuss all this, and then to recommend whether a diagnosis of IPF can be made, and then whether treatment is required, what kind of treatment, whether we need a lung biopsy. Because if we can confidently say that it is IPF based on our exclusion of other causes, we don't have to do a biopsy. We may not even have to do a bronchoalveolar lavage. We may diagnose based on CT scan and a careful history and blood tests. So why do we need all these tests? Again, is it really IPF? I'm sorry to insist on this. Are you sure it's not something else? This is the question that you always have to be asking yourself. It's one of these conditions where you have to be skeptical. And generally, in the whole of medicine, I would say, when you're calling something idiopathic, are you sure it's not something else that's causing it? So look further. Try to go to the very limits of your knowledge and try to determine whether there could be an explanation for all the symptoms that your patient is having. So we need to rule out the known causes of ILD. So again, expertise is important. You need to study a lot if you can in this field, but it's very, very rewarding once you make sort of a doctor house style diagnosis. It's very interesting. So you're trying to rule out generally an inflammatory cause. So you determine whether the treatment should be anti-inflammatory or antifibrotic. I did mention this before. So all these tests are trying to determine whether you're going to give your patients corticosteroids or something else, which is an antifibrotic medication that slows down the disease progression. So you're trying to make this distinction. You need this to have this fork in the road where you're trying to decide which way you will be looking for the best treatment. You establish a baseline from all these tests before you start treatment, because then you will be following up your patient for years to come. So basically you might be following them for every 3 to 6 months, and then you will find whether his lung function is going down, whether he has any adverse effects from medication. All these things need to be done at the beginning. And you're trying to also determine, if you are going for a diagnosis of IPF, whether your patient is eligible to receive antifibrotic treatment. And we'll discuss about treatment later. But the treatment is not for everyone because it does have some side effects. And patients may prefer some side effects over other side effects. I will talk about that later. Depends on their comorbidities. There may be contraindications to some of these treatments. And then access to antifibrotic treatment is based on local reimbursement rules. So I live in the UK where we have cutoffs where we cannot prescribe antifibrotics to everyone. Even if we call it IPF, not everyone can have the medication because of costs. So quite important to check your local laws and regulation wherever you are in the world. Now, here are some findings in support of the diagnosis of IPF and things to think about. So this is where I try to go into a little bit of a differential diagnosis and how to think about placing IPF in the wider scope of interstitial lung disease. So clinical history. Generally, you have a patient who is slightly older, right? So this is quite an important thing to note. At an older age, there are fewer and fewer things that could be causing fibrosis. So you might think about IPF. Progressive respiratory symptoms, you might have that, right? When we discussed the dyspnea, the dry cough, unusual reduction in exercise capacity over time, recently, generally, in the last, let's say, 2 years, patient was absolutely fine. You don't have an explanation otherwise. They don't have heart failure. They don't have anything that could explain that. Think about fibrosis as well. It's not explained fully. I've mentioned this already. And then family history, very important. Very, very important, okay? There's more and more awareness that familial interstitial lung disease is a real thing. Other family members could be at risk. So if your patient has IPF, you might want to ask whether they have any other family members who might be suffering with their chest. And maybe those people could have IPF as well, or some sort of interstitial lung disease, but they've never been really checked for it. Other family members also can have other ILDs. So not everyone in the family necessarily has to have IPF. This is very important. I'm quite interested in this sort of familial ILDs because they are fascinating in the sense that you have a genetic predisposition that may be common for all members of the family who are affected, but they end up having different phenotypes of interstitial lung disease, different types of interstitial lung disease. And the family members might also have signs of premature aging. Like I mentioned before, there's a premature aging of the lung, but there may be a premature aging of the entire body. So for example, people who have short telomeres, they might have these sort of clinical features that you can pick out, like early gray hair. So say they start to go gray in their 20s. This is something that, you might want to see whether they have any other family history of similar things, early menopause, things like that. You might want to ask about family history, but I realize it's very hard. You need a long time to evaluate patients with IPF. You need to collect a lot of information. So environmental history, you're trying to rule out things like professional exposures in their workplace, and basically to try to determine whether there may be some sort of reaction to something in the environment. So I've put a few things here. Let me just, so basically this is it. So you're looking for potential evidence of recurrent lung injury. So like I said, you might have people who have been working on construction sites or sites all their lives. They may be smoking. So that could be like repeated lung injury. And if they have impaired lung repair mechanisms, they might develop IPF. Asbestos can cause asbestos inhalation. Everyone talks about mesothelioma, pleural plaques, etc., but it can cause lung fibrosis, and it can cause lung fibrosis that looks exactly like IPF. So again, if your patient has been working with animals, birds, inhaling all kinds of organic materials, living in damp environments, things like that, mold exposure, these could be triggers for hypersensitivity pneumonitis, which again can look similar to IPF on CT scanning, but is treated completely differently. So all these things are very important to note. Then the medication history, very important. Any unusual medication your patient might be on. Are there any of the common drugs that cause ILD in your patient list or in their medical history? Amiodarone, chemotherapy, things like nivolumab, things like that. You might ask about that. You need to look for a time correlation generally when you're thinking about a drug-induced ILD. So there might be some sort of connection between when the patient first started taking the drug and developing respiratory illness. There is this very good website, so pneumotox.com. So if you go there, you can check if various random medications have been ever associated with lung toxicity. It's a very useful website. This is very important. You check for connective tissue diseases. You need to be a mini rheumatologist, if you could say this. So your patient may have already been diagnosed with connective tissue disease, or the ILD itself could be the initial presentation. So it's not unusual for us to find in this field, you have a patient who's been referred to you to check if they have IPF, but you find out that they have rheumatoid arthritis. And the lung was the first organ affected even before their hands had any symptoms. So you need to be careful, because you sometimes can fall into the trap of calling things IPF when they are really something else. So I've mentioned this. Skin cracking around the fingertips, so around here, this could be myositis. Difficulty swallowing food, thickened skin on their fingers, microstomia. Think about scleroderma, that can cause ILD as well. Dry mouth, dry eyes, that's a feature of Sjogren's disease, which again can cause interstitial lung disease. All these things are inflammatory in nature. They are treated completely differently compared to IPF. So it's important to make the distinction. So generally what we do is we do an antibody panel to screen for these connective tissue diseases which have known antibodies. And then obviously, like I mentioned here, if we find a connective tissue disease, the diagnosis is no longer IPF. This is something that it took me a while to understand as well, but basically it's something else because you treat it differently. Pulmonary function tests, very important. So ideally you should have a standardized lung function performed in a lung function lab, because that gives you good values, because you will use these to monitor the condition. You will have to make treatment decisions potentially based on these lung function results. There may be issues around reimbursement for drugs, etc. So really try to get very accurate and correct lung function as much as possible. The DLCO is useful to have in addition to spirometry. So you are looking at the forced vital capacity decline over time, generally to monitor the disease progression, but DLCO is usually more sensitive and it can give you some indication here. So for example, if there is a disproportionate decrease between the FVC, which is maybe relatively normal, but the DLCO is severely impaired, that could be a sign that the patient might have pulmonary arterial hypertension or emphysema. So there are a lot of things that you might gain from doing a complete lung function test. And then, like I mentioned, the treatment eligibility can be based on lung function results. Radiology. Now we're coming into the territory where we really need to be good. We need to have the expert opinion of a radiologist when we're making this diagnosis. Absolutely essential to get a high resolution CT scan. This is the scan that you need. It's a non-contrast CT scan with thin slices. So basically that gives you a high enough resolution to determine the patterns that are consistent with IPF or with other conditions. And there are a couple of patterns that I will outline in the next slides. So the definite usual interstitial pneumonia, the UIP pattern, this is what we're looking for. This gives us the highest diagnostic confidence. The probable UIP pattern is almost like this one, almost, but still it can be caused by several other things. And then if the pattern becomes a little bit fuzzier with other elements involved, we call it indeterminate, where we might need more investigations to have more arguments in favor of a diagnosis of IPF. So then there's also this alternate diagnosis pattern, not consistent with IPF, where the IPF diagnosis is actually unlikely just based on the radiology, on the appearance of the CT scan patterns. So very important to have a good interpretation of the high resolution CT scan, usually discussed with the radiologist in the multidisciplinary team meeting. Pattern characteristics. So obviously, if you want the full description, I recommend this guideline. It's fairly recent. It contains a lot more. It contains images. So you might want to check this out if you're interested in learning more about IPF. Like I said, it's a complex disease. That's why this video is so long. But it's very important to cover as much as this as possible because many clinicians don't have awareness of this. So these are the patterns that I mentioned before. So I'm just going to quickly go over this. You don't have to worry too much about it. You can pause the video if you want to read, but I would go to this guideline and actually look at the pictures because the pictures you will remember better. But a few things to mention here. So generally, IPF causes this UIP pattern that is generally fibrosis, which is distributed in the subpleural basal areas of the lung. So it's around the periphery and lower parts of the lung. And then you might have this feature of honeycombing, which defines the definite UIP pattern. In probable UIP, it has the same distribution in the same areas of the lung, but you don't have honeycombing. You might have reticulation, some traction bronchiectasis, things like that, but no honeycombing. And then indeterminate, it doesn't really fit with either of these. Maybe it has the right distribution, it may be in the right area of the lung, but you still don't have these features. You don't have honeycombing. It's not very clear. It could be an early UIP pattern, or it could be truly indeterminate for UIP. And then obviously you can have an alternate diagnosis pattern when the distribution doesn't fit with IPF at all, doesn't fit with what you would see in an IPF patient, doesn't fit with the UIP pattern. You might have other things that are really not found generally when you have fibrosis and IPF. So IPF is a fibrotic disease. You will have fibrosis and not much else. So you wouldn't find cysts, generally nodules, consolidation. Pleural plaques are a sign of asbestosis. If you have a dilated esophagus, it could be a sign of connective tissue disease. So these things are, even the CT scan, if you have a good radiologist on board and they know what to look out for, they can give you a diagnosis just by looking at the CT scan, or you may be very, very close to a very confident diagnosis, which I think is fascinating. And this is a non-invasive test. You just do a CT scan and you're getting closer to a very complex diagnosis. The bronchoalveolar lavage, the bronchoscopy with a lavage, is a great procedure when you are not sure. So basically this increases your diagnostic confidence because it rules out inflammation in the lungs, which can be a feature of chronic hypersensitivity pneumonitis, for example, or some sort of a CTD. So that makes you make this distinction, inflammatory versus fibrotic, which has very important treatment implications, steroids, non-steroids. So these are very, very important to know. The differential cell count that you do in the BIL fluid, that's really what is giving you the indication whether you have inflammation or not. So generally high proportion of lymphocytes, over 15%, would not be consistent with idiopathic pulmonary fibrosis. You need to look for another cause. High neutrophils can be an adverse finding. So patients with IPF who may have, for example, low lymphocytes, everything is consistent, but their neutrophil count is a little bit high. They sometimes have a worse prognosis for some reason. And then before you do the actual lavage, always consider whether the patient is fit enough to do it. You don't want to expose your patients to undue risk. You might sometimes have to treat your patient based on the highest probability of a diagnosis and see how they go, rather than do invasive procedures on and on until you find the perfect diagnosis. Sometimes what happens is patients get given a working diagnosis of IPF because, look, if you have IPF, that's the most serious condition you can have in terms of fibrosis. It would have the worst prognosis. So you want to treat that with antifibrotic medication and slow it down. because it's not reversible. The other conditions, if you treat them with antifibrotic medication, you might still slow down their scarring, but you might at some point decide to give them a small low dose of immunosuppression of steroids, and they might actually recover. But in IPF, that doesn't work. So you're trying to see whether you're on the right track or not. Now, the normal BAL differential cell count, I thought I'd add this in here because you might want to pause and have a look at this. This is normally what you would see in a normal bronchoalveolar differential cell count. You can check this paper if you want to have more information on how the bronchoalveolar lavage is used in diagnosing ILD, because it's a very important procedure. It's a fairly easy procedure to do, and it gives us a lot of information just from this differential cell count, which is crazy. And then you can also check for, infection, bacterial colonization, fungal colonization, things like that, which can also help you make a diagnosis. So you're Dr. House here. You need to check for little things that give you clues. And you're putting all of this together into a diagnosis of IPF, all the stuff that I've discussed before. So you need to have a compatible clinical history, the right age for the diagnosis, compatible HRCT pattern, right? So definite UIP, probable UIP, an autoimmune screen, which is negative or with minimal changes that are not consistent with a known connective tissue disease. And your rheumatologist, your friendly rheumatologist might help you rule out something. They might see the patient and then actually give you an assessment if you find something on the autoimmune screen. You also want to make sure that chronic hypersensitivity pneumonitis, which is again a great mimicker of IPF, is not there. So, you have a good history. They have had no exposures to anything, no sensitizations, no antigens. Sometimes you can do blood tests as well for checking, for example, for bird or farmers, precipitants, things like that. That can, again, help you rule out hypersensitivity pneumonitis. You have no other clinically significant environmental exposures, no asbestos notably, no offending drugs, no evidence of inflammatory BAL differential cell count, like I've discussed before, if you have done a BAL. If a lung biopsy was decided upon and was done, if that shows a UIP pattern, that again can be a strong indicator for a confident diagnosis of IPF, but there are complexities around the biopsy, so I won't go into this here. But one, it's risky. Two, you might biopsy the place where there's no UIP pattern. So again, it's not a perfect thing. Generally, people who have a lung biopsy have the highest confidence in their diagnosis, but it's not always possible. And actually in day-to-day practice, if you follow the steps up to the biopsy, you generally end up having a diagnosis by then. So all this data is discussed in this fantastic interstitial lung disease multidisciplinary team discussion. This generally consists of the people that I've listed here. They all talk about the case and they try to come up with the best possible diagnosis while minimizing the invasiveness of the tests required to make that diagnosis, and generally to determine which therapies might work best. There are guidelines on how to diagnose IPF. So if you want to check this guideline, very, very useful. I think I've put this before in the slides. This will give you a lot of information. I've summarized some of the recommendations in the guidelines. So for all patients with clinically suspected of having IPF, apparently no known cause, you haven't found anything, newly detected interstitial lung disease, generally you need to be doing these things. Take a detailed history, both medication use, environmental exposures, etc. Serological testing, so antibody testing to exclude CTDs, and have an MDT discussion. So this is basically I'm trying to go from like the broad picture to try to funnel it down to simpler and simpler recommendations. But I think it's important to have the full context and not to just be looking for IPF, but not ruling out things. Then you have two scenarios here, also in the guideline recommendations. So if your CT scan shows a pattern of UIP, so usual interstitial pneumonia definite pattern, then you would not require a BAL fluid differential cell count. You wouldn't need to do a bronchoscopy. This gives you enough confidence in the diagnosis if you've ruled out everything, you've done the serological testing for all patients, checked for environmental exposures, good clinical history. You do not need to do any invasive procedures. You have the diagnosis. That's it. Scenario 2, also, if you have a pattern that's not definite UIP, it's probable UIP indeterminate or an alternative diagnosis. That's where you need a bit more information. So you could do a bronchoalveolar lavage. You could potentially do a surgical lung biopsy, but consider the risks. It can be very risky for patients. And they haven't made a recommendation in the guideline regarding other forms of biopsy. So basically the ones that you would do via the bronchoscopy, to do a transbronchial lung biopsy or a cryobiopsy. So you wouldn't necessarily want to do these things. You could do it if you have access to them. They may or may not give you the diagnosis. It's not very clear yet, but these are the recommendations in place. Let's move on to treatment. Treatment is complex in IPF, of course, like this entire presentation, but I hope it was helpful so far. Keep watching. It gets interesting with the treatment as well. So first of all, like with any condition, you're not trying to just give a tablet that will fix it. Doesn't work like that. You need non-pharmacological treatment in the first instance. Further avoidance, further lung injury would not be good. It would make your patient's condition progress because their lung repair mechanisms are impaired. So you're trying to help them avoid any further lung injury. So smoking, inhaling dusts, things like that wouldn't be a good idea. Pulmonary rehabilitation, it's very, very important. So patients who have been diagnosed with IPF, they should go on an exercise program to work with a physiotherapist, to know how to improve their breathing capacity, to learn how to breathing techniques, to cope with breathlessness. These things are very important. Most patients, especially if their diffusion capacity is low on their lung function, should have an oxygen assessment to determine whether they would need ambulatory oxygen only when they're walking around, or if they need continuous oxygen, because obviously if they are hypoxemic, they will have a bad outcome very quickly. Counseling is also very important. In some countries, there are specialist nurses or specific counselors who know how to deal with patients with IPF, to answer their questions, to help them with symptom management, with medication side effects. It's very important to have this support system for the patient. Cognitive behavioral therapy can sometimes work as well, because you can imagine patients who are progressively having fibrosis of their lungs, they find it harder and harder to breathe. They may panic when they become breathless. So it's important for them to learn how to cope with their condition as well. So these things most people don't even think about, but these are the cornerstone of treatment. You start with this first. You also need to treat comorbidities. If your patient has heart disease, if your patient has gastroesophageal reflux, for example, that can also be a trigger that could provoke further lung injury if patients have reflux. So that needs to be treated. Then we move into the pharmacological part of things. So we have antifibrotic medication. That's the cornerstone. I didn't put any steroids here. So for stable IPF, that's not an exacerbation of interstitial lung disease, you would treat with antifibrotic medication, the goal being to slow down the process of fibrosis. And also you might need sometimes symptomatic therapy. So for example, morphine may be prescribed sometimes for patients who have a lot of coughing, a lot of breathlessness. It can sometimes help to have as needed opioids. So these are things that you need to consider as a clinician to provide your patient with all this treatment that is very holistic, and I understand that. So the antifibrotic medication, maybe all of you have been waiting for this. Maybe this is what you've been waiting for in this video. In 2022, we have two approved medications. One is called nintedanib, the other is called pirfenidone. They are both relatively similar in their efficacy, although they haven't been compared head to head, and I don't think these studies would necessarily happen because obviously it's competing companies that produce these medications. But they both work. They generally slow down the fibrosis. They have slightly different mechanisms of action, but they seem to be working. The doses are as here. These are the full doses. Sometimes you need to reduce these doses of medication because the patient cannot tolerate the full dose, and that's acceptable. Or sometimes patients need to stop for a while and then resume the treatment. That can happen as well, also due to side effects, due to changes in their liver function tests, things like that. So it's important to have this support system as part of this interstitial lung diseases team. Specialist nurses can have a great role in monitoring the disease, so that's really, really important if you have access to that. If not, as a clinician, you need to be looking out for all these common adverse effects. So generally, if I were to separate the two medications, many patients on nintedanib do have quite significant diarrhea. Sometimes they need to take loperamide almost every day to counteract it, which is, it's a pain, but many patients actually want to take the medication if they know that it will slow down their fibrosis. With pirfenidone, if you have patients who have, significant sun exposure, it can cause photosensitivity. So they may need to use sunblock all the time when they go out into the daylight. Again, with nintedanib, sometimes if patients have had a history of significant cardiovascular events, if they have some sort of an aneurysm, things like that, it may be contraindicated. So this decision whether to go for nintedanib or pirfenidone is not necessarily made based on efficacy. It's made on patient preference. So you need to explain both medications to your patient if they are available for their treatment, and let them choose. I think that's the best way because they will be dealing with side effects, and many patients have at least some side effects of antifibrotic medication. Now, the currently approved antifibrotic medication does slow the progression of IPF by about half. So they work, but they're not perfect. But if you establish a diagnosis early and you start them on treatment early, patients will definitely have a better outcome. So I think it's very, very important. I think that was my presentation. So hopefully this was helpful. If you have any questions, do leave them in the comment section below. I know this was a very, very long video about IPF, but it's a fascinating disease. It's a very complex disease, and this doesn't even cover everything. But I hope it was comprehensive enough to give you enough meat, let's say, to work with if you are curious about learning more. And I think the recommendations that I've made in some of the previous slides, so if you roll back this video and read the guidelines, for example, these may give you a better understanding about what IPF is, how it's diagnosed, and hopefully you will end up helping your patients a lot. All the best, and I'll see you in future videos.